Ashley Robertson with RBC Consultants. Thank you for joining us for tonight's Skin Chat webinar. Tonight's webinar is Racial and Ethnic Variations in Atopic Dermatitis Patients and the Role of Skincare in Improving Outcomes. This evening, our presenters are Dr. Mercedes Gonzalez and Dr. Heather Woolery-Lloyd. Dr. Gonzalez is a clinical assistant professor at Dr. Philip Frost Department of Dermatology and Cutaneous Surgery, University of Miami, Miller School of Medicine, and Florida International University, Herbert Wortham College of Medicine. Dr. Woolery-Lloyd is director of the Skin of Color Division, Dr. Philip Frost Department of Dermatology and Cutaneous Surgery, University of Miami, Miller School of Medicine. We would like to thank our sponsor this evening, CeraVe, for making this educational event possible. So before we begin, we have a couple of technical, if you have technical issues, you are able to call in using your phone. Just select the phone call in the audio pane and the dial-in information will be displayed. At the end of this webinar, a survey will be emailed to you within 1 to 2 days, and we would greatly appreciate it if you could fill out this survey. If you're having any technical issues or if you have a question for our faculty, please submit them in the question chat pane on the right-hand side of your screen. And also, within 1 to 2 days of the webinar, you will receive a certificate of attendance as well as a recording of this presentation. Again, if you have any questions, please submit them during the presentation using the question chat pane on the right-hand side of your screen, and our speakers will answer those questions live at the end of the presentation. So without further ado, I would like to pass the floor virtually to Dr. Gonzalez.
Good evening, everyone. Thank you so much, Ashley, for that kind introduction. And tonight we're going to start, I believe, with a polling question, which is up next. So this is the polling question. Select your answer after I read the question. Which of the following is a prominent clinical feature of atopic dermatitis in patients with skin of color? A, bright red erythema, B, perifollicular accentuation, C, less severe pruritus, and D, skin pain. Please vote. Very good. So the majority answered correctly. And so we will discuss a little bit more about these differences of the clinical features in patients with atopic dermatitis and with different and darker skin tones. We're going to discuss a little bit more about that tonight. But yes, the correct answer was B, perifollicular accentuation is one of the more prominent clinical characteristics of atopic dermatitis in skin of color patients. So tonight's Skin Chat is actually going to discuss this paper that's in press currently that both Dr. Woolery-Lloyd and I worked on, titled Insights in Skin of Color Patients with Atopic Dermatitis and the Role of Skincare in Improving Outcomes. And the background or the idea behind this paper stems from the increasing amounts of data. Number one, we know atopic dermatitis is a chronic immune-mediated skin disease that is prevalent globally. And there's an increasing body of literature pointing to the fact that there are variations in the epidemiology, clinical presentation, disease course, and the impact on quality of life amongst different racial and ethnic populations living with atopic dermatitis. And we do also have increasing data and good data from large cohorts and large subsets of the population, both in the US and in other countries, that there shows that there's differences in prevalence. For example, in the United States, we know that there's a higher prevalence of atopic dermatitis in African American children, as well as it seems to be there's more persistence in African American children, as well as there are now some data showing racial and ethnic disparities in the healthcare utilization and access to therapies in regards to treatment for atopic dermatitis specifically. And given this background, in order to better understand the atopic dermatitis in the skin of color population, we set these objectives for the group. So the group convened with these 4 objectives in mind. First, we wanted to better understand the unique aspects of atopic dermatitis in skin of color. Then we wanted to discuss the role of moisturizers and cleansers in treating atopic dermatitis in skin of colors as well as discuss nuances in the treatment overall, as well as lastly, explore moisturizer and cleanser ingredients, offering insights into the specific role of common key ingredients in moisturizer formulations. The methods, it was a panel of 6 dermatologists from the United States convened in a virtual meeting in May of 2021 to address these objectives. And we used a modified Delphi process. The review that's in press currently summarizes the distinct features of atopic dermatitis in populations with skin of color and provides recommendations on the role of skincare for treating atopic dermatitis in diverse populations. The recommendations are based on the available literature as well as the expert opinion of the panel. This was the literature search that occurred about a month before the meeting. It was primarily PubMed, and a secondary source was Google Scholar, and the review included English language literature published from 2015 through March of 2021. The search term used here are listed here. We searched racial ethnic differences in clinical presentation and sequelae of atopic dermatitis, skin barriers, skin of color barrier structure and function, skin lipids, ceramides, tolerance to treatments, differences in expected treatment outcomes, clinical and cultural significance of cleansers and moisturizers in the skin of color individual, and cleanser and moisturizer ingredients, as well as OTC skincare efficacy and tolerability, as well as skin irritation. So a pretty broad range of search terms. We included original research, clinical guidelines, algorithms, relevant reviews, and evidence-based recommendations that describe current practice. Publications that were excluded were ones that didn't address atopic dermatitis and skincare in skin of color, and publications in languages other than English were also excluded. The results yielded 73 papers that were deemed clinically relevant to inform the current best practices in skin of color patients with atopic dermatitis and skincare use. So the ones that were thought to meet the objectives, 73. We did note that robust comparative studies on skincare use for prevention and treatment and maintenance of atopic dermatitis in skin of color patients as monotherapies was scarce and did not allow for systematic review. And so the recommendations made are based on recommendations on skincare specifically in the clinical guidelines that were found, consensus papers that were found, and algorithms per region with different racial and ethnic populations were discussed and summarized in the paper. And these are the results were the advisors, after this review and discussion, agreed on these 5 statements listed here. I'm not going to read them right now on this slide because I'm going to discuss them each one in detail. I will discuss statements 1 through 3, and Dr. Woolery Lloyd will discuss statements 4 and 5. So the first statement agreed upon and described in the paper is atopic dermatitis is a common chronic inflammatory skin disease with a multifactorial pathogenesis that includes genetic, immunologic, and environmental factors. These factors may vary amongst diverse populations. So what we know is what we have found with this literature search and looking at the variations specifically in epidemiology of atopic dermatitis in the different racial and ethnic populations. Number 1 was prevalence. So there are now an increasing body of literature showing differences in prevalence with large numbers of patients. In the United States specifically, several studies have shown higher prevalence of atopic dermatitis in Black children compared to white children. In a longitudinal large cohort study, atopic dermatitis incidence and also the persistence of the disease was higher among non-Hispanic Black children when compared to white non-Hispanic children. In addition, one study also looked for severity and showed that there was a greater severity of atopic dermatitis in Black children when compared to white children after adjusting for the erythema score in the score, which, as we know, erythema can be appreciated in skin of color patients with atopic dermatitis. So they may have lower erythema scores on the SCORAD when their erythema is actually a more moderate to severe. So even after adjusting for that, they had a greater severity in Black children as compared to white children. This is one prominent study because it included, from the United States, epidemiologic study including over 100,000 families in the United States. It's the National Survey of Children's Health that's done periodically to assess the health of children and families in the United States. In this study, African American children were found to be 1.7 times more likely to have atopic dermatitis than their white counterparts, even after adjusting for household income, parental education level, and environment. This is also true globally, however. There are differences in prevalence in different regions, and specifically overall rates of atopic dermatitis higher rates were found in Africa and Oceania as opposed to regions such as India and Northern and Eastern Europe. In addition, this is an interesting study that showed increased utilization of healthcare by Blacks and Asian Pacific Islanders compared to other populations and whites. So they're more likely to visit physicians and access medical care for treatment of the atopic dermatitis when compared to white patients. So that's differences. In addition to differences in prevalence, there are also differences in the skin barrier and in some of the pathophysiologic factors when it relates to atopic dermatitis. So specifically, we know filaggrin, right? Filaggrin is one of the more widely studied genes, skin barrier genes in atopic dermatitis. It was first found to be associated with ichthyosis vulgaris in 2006, and then subsequently found to be associated with an increased risk of developing atopic dermatitis shortly thereafter. Filaggrin is a gene that's it produces a protein called profilaggrin that then subsequently breaks down, and it plays a very important role in the not only structure, so it actually is a structural protein that is an important role in forming the corneocytes or the stratum corneum, but it also plays a big role in the function of the skin barrier, right? So its breakdown products are, one of them is natural moisturizing factor that helps to hold hydration, as well as organic acids. So it breaks down to natural moisturizing factor and organic acids. The organic acids contribute to the pH of the skin. So a very important protein in structure and function. And so here it's been widely studied, probably because we've gotten better at assessing for this genetic, this gene, testing for this gene and mutations in this gene. And so what we know is that there's variations across different ethnic groups that have atopic dermatitis, and several studies we know originally were done with white European populations, and here they have seems to be that they have a higher prevalence of these null mutations or loss of function mutations in the filaggrin gene. So consistently, loss of function mutations were found in up to 50% of European and 27% of Asian patients with atopic dermatitis. So they were, however, in the African American population, they were 6 times less common when compared to European American patients, even those that had severe atopic dermatitis. Similarly, in Korean, Japanese, Chinese, Singaporean, and Taiwanese populations, all of these populations where filaggrin null mutations have been looked at, they have found that they are unique, so unique mutations to the relative ethnic group. And they rarely exhibit the mutations that are commonly observed in the white population, so showing differences in the genetics of atopic dermatitis amongst these different ethnic populations. Overall, filaggrin mutations seem to play less of a pathogenic role in patients of African origin than in individuals from European or Asian ancestry. This is a busy slide, basically summarizing the studies that were reviewed in detail. So here on the right-hand side, you see the reference, and on the central column, you see the overall results specifically. Overall, the gist is that the loss of function or null mutations in this filaggrin gene vary by population and have a lower frequency in atopic dermatitis patients of East Asian and of African descent. So it seems to be playing less of a role here. And it's possible that there is another unknown, yet unknown genetic mutation that's more common in this population. here, this last study, I will point out here, because this one, it was in the United States, looking at African American patients compared to white patients, and found only 5.8% of African American subjects had the filaggrin null mutation. In addition, other differences, reports have shown that there may be an increase in transepidermal water loss and a decrease in ceramides in black skin, and this may contribute to pruritus and its related conditions, or some symptoms in inflammatory skin diseases. Here, in addition, a small study has shown variations in mast cell composition. It has been shown in black skin, which may be of functional importance in atopic dermatitis and other skin diseases. So now on to the second statement. Here, clinical and morphological differences of atopic dermatitis in patients with skin of color have been described, including the presence of follicular and /perifollicular papules and xerosis in black atopic dermatitis patients, which can be culturally stigmatizing. So clinical features in atopic dermatitis in skin of color patients. We know atopic dermatitis is chronic relapsing erythematous disease with these recurrent dry plaques. However, some features may be more prominent in patients with skin of color. For example, erythema. The appearance of erythema is different in patients with skin of color. Here, the lesions may appear, instead of bright red, may appear more reddish brown or more violaceous or even gray. Very lichenified lesions may appear dark brown or even a dark shade of brown, close, or very deeply pigmented rather than bright red. Perifollicular accentuation, as was alluded to in the polling question, is very prominent. This is especially true on the trunk and the back, where you kind of can roll your hand over the trunk and you feel, the skin feels bumpy. And this is sometimes something that's very bothersome to parents and patients, and really want this treated. And sometimes one of the harder things to make smooth. In addition, lichenification is much more prominent in patients with skin of color, as well as pigmentary changes, both hypo and hyperpigmentation. So hypopigmentation is going to become more apparent and is much more culturally stigmatizing in skin of color patients, and it can persist as well. The distribution of atopic dermatitis lesions on the body may differ amongst the different racial and ethnic populations as well. In some skin of color populations, such as those of African descent, lesions may present more frequently on the extensor surfaces than on the typical flexural lesions. And here on the right, you see some examples of the erythema that you may notice that here it appears a little bit more grayish brown or reddish brown rather than a bright red erythema. And here you can appreciate a little bit of the dyspigmentation, hypopigmentation that is often seen. Two studies looked at the diagnostic criteria for atopic dermatitis in African populations, and they found a poor positive predictive value for the diagnostic criteria. This is because the clinical features are different. For example, the distribution sometimes may be different, right? So in some of the diagnostic criteria, the distribution is flexural surfaces when you're a child, and in some populations, the more common distribution may be extensor surfaces. Adapted, validated, and clinician-friendly criteria are needed for research and clinical use, and this is an area of great need, because the current scoring tools really emphasize erythema as a big component of the score. And as mentioned, erythema is very difficult to assess, and severe erythema is often under assessed, right? So it's downgraded, and so that contributes to a lack of a true assessment of the patient. So more severe patients tend to be graded and as more mild. And so there has been a version of the score that was developed and adapted, focusing on the variations of the severe atopic dermatitis in skin of color. In addition, pruritus has been shown in one study here. This was a study that used data from atopic dermatitis patients of Asian and African descent that were living in the United States and Europe. And this study indicated that itching may actually be more frequent and more severe in this population. In addition, patients with black skin are also more likely to be diagnosed with prurigo nodularis in addition to their dermatitis. So here lastly, it's the dyspigmentation, as we mentioned, another prominent clinical feature of atopic dermatitis in skin of color. Patients who have a higher risk of developing post-inflammatory dyspigmentation, which can last for months to years, so longer lasting. In less severe cases, this dyspigmentation may subside within weeks to months. However, chronic excoriation can result in permanent dyspigmentation, which we've all seen this, where the scratching is so deep where they actually get the depigmentation that can be permanent. So on to statement 3. Cultural factors related to bathing and moisturization preferences need to be considered. Increased scrubbing, cleansing, and fragrance use may be more common in some skin of color populations and vary according to cultural and geographic norms. Cleansing habits should be considered when treating atopic dermatitis in these patient populations. As mentioned, we know skin barrier dysfunction is one of the main pathogenic factors in atopic dermatitis. It's very central to the disease, and thus treating this or addressing this as part of the treatment plan is essential. We know the genetic variations that kind of are inherited. There's variations in different genes, filaggrin specifically, and others. This all contributes to skin barrier breakdown and dysfunction. And it is important that skin barrier repair with the use of skincare and moisturizers is an essential component of the management of atopic dermatitis. And indeed, that's what the review of the literature found, that when we reviewed and looked at atopic dermatitis guidelines from various regions globally, we found that indeed skincare was mentioned as an important part of the management of atopic dermatitis across the board. Some of the guidelines very briefly mention use of moisturizers as a one additional word or one small sentence to use in addition to the prescription topical corticosteroids and other prescription topical treatments. Other guidelines, however, go into much more detail and describe specifics about which moisturizers and emollients should be used and how often they should be applied. However, few guidelines address specifically the racial and ethnic specific skincare as an individual approach to atopic dermatitis. This is these two tables on the right here are taken from the position statement on atopic dermatitis in sub-Saharan Africa. And here, this study is a nice study. It was a survey of over 100 practitioners who treat atopic dermatitis, including dermatologists. And what was found here on the bottom, the question is, what do you use for treatment? And as you can see across the board, here's about over 94%, the use of moisturizers is an important first line, basic and crucial step in the long-term management of an atopic dermatitis control, in addition to the topical corticosteroids. However, this article does point out that in some areas there is ease of access to essential drugs and moisturizers, but in other areas of sub-Saharan Africa, it is difficult or impossible to obtain. Thus, the wide use is variable. Briefly mention the Asia Pacific atopic dermatitis guidelines. And here, this guidelines goes into a little bit more detail about the use of moisturizers as part of the treatment of atopic dermatitis. They recommend moisturizers, specifically those that contain virgin coconut oil, ceramides, glyceric acid, shea butter, and hyaluronic acid as the mainstay of treatment, and should be liberally and frequently used in the prevention of atopic dermatitis prone skin. As a practice point, these guidelines state that moisturizers must be suitable for the patient's climate, humidity, and environmental conditions. And this is an important point, kind of and something that we also mentioned in the statement is that to consider cultural norms and the patient's environment when making recommendations, right? So it's not a one moisturizer recommendation type fits all. It's about asking patients where they live, the humidity, the climate, and their cultural norms in when you're discussing their individualized treatment plans. In addition, these guidelines also recommend the use of the moisturizers up to 3 times per day, which is more than some of the other guidelines recommend for application. Lastly, the European-based guidelines recommend skincare also as a part of the essential therapy, which focuses on treating the skin barrier dysfunction as monotherapy or as an adjunct to prescription therapy and maintenance. The guidelines specifically point out specific benefits to using moisturizers that contain skin lipids, such as ceramides. And so overall, the guidelines globally that were reviewed point out that skincare products, OTC or over-the-counter skincare products such as moisturizers, in the management of atopic dermatitis as adjuncts or alternatives to treatment, to prescription treatments for not only prevention, right? So a mainstay of treatment as part of the treatment regimen when you're treating an active lesion and as part of maintenance treatment. And so with this, I'm going to now move pass the floor virtually to Dr. Heather Woolery-Lloyd, who's going to go into more details about the use of moisturizers, the treatment of atopic dermatitis.
Thank you, Dr. Gonzalez. So I'm also going to start with a polling question. So let's see that first polling question. So the question I have for you today is, do topically applied ceramides affect ceramide levels within the epidermis? So you can either select yes or no. I'm curious to see your response. I think that I'm going to present some interesting data today, so I'm curious to see. Okay, so the answer you have given is yes. So we will see in my presentation if that is correct. I'll give you a hint, it is, but I'm going to go ahead and get started. So when we talk about skincare habits in our skin of color patients with atopic dermatitis, it's really important to understand that in some of our skin of color patients, the skincare habits are different. So I practice in Miami. I have a huge Caribbean population, and definitely in that population, patients are much more likely to over cleanse and have this concept of scrubbing the skin clean. In other populations, that population, African American and also Caribbean, is very much more likely to use washcloths. And in Asian populations, exfoliating cloths, which is a part of the bathing routine in some Asian cultures. And then also, we also have more highly fragrant product use. So in the Latina population here, it's very, very common to use perfumes on babies. And in my local drugstore, there's a whole aisle of perfumes for babies, which we know isn't helpful if those babies are atopic. So skincare really becomes important in our skin of color atopic dermatitis patients. So when we think about cleansers, I just want to briefly review different types of cleansers. The more alkaline cleansers were the original cleansers. So the soap and the calm bars are the original cleansers. Then liquid cleansers and non-greasy cleansers were introduced, and they started to become slightly more acidic. But really what we'll be focusing on today is the multivesicular emulsion system, which is truly in the correct pH that we need for the skin, which is a pH of 4 to 6. So here you go. This explains why it's so important. Our healthy skin has what we call the acid mantle, which has a pH of between 4 and 6. Tap water has a pH of 7 or more. So it starts to be slightly alkaline, actually, tap water. And of course, traditional soaps are alkaline. Well, why is this important? Well, it's important because when you use cleansers that have a low pH in the acidic range, there's a very low risk of irritation, which of course is so important for our skin of color patients. And then if you have cleansers with a neutral pH, there's a medium risk of irritation, and traditional soaps that are alkaline have a very high risk of irritation, which is very important for our atopic patients. So a high elevated pH in our cleansers increases inflammation, decreases stratum corneum cohesiveness, and decreases our barrier. So pH in cleansers are really important. Now, after cleansing, we all moisturize, and Dr. Gonzalez presented so beautifully that a lot of the guidelines, international guidelines, recommend moisturization. Well, so all of us who treat atopic dermatitis tell our patients to moisturize after cleansing. This is a very tiny study, only 10 subjects, but a nice little study looking at the timing of moisturization and how that affects hydration. So one group did a 10-minute bath and no moisturizer. The next group did a 10-minute bath and immediate moisturizer application, which is what I typically tell my patients. The next group did a 10-minute bath and delayed, so 30 minutes later moisturization. And the group treatment regimen D was no bath and an immediate moisturizer was applied. So what did they find? Interestingly, emollient alone caused the most hydration in the skin, increased the water content the most, 206%. But bathing with immediate emollient or bathing with an emollient 30 minutes later were similar, 141%. So an increase in hydration of around 41%. And not surprising, bathing alone, meaning no moisturizer, actually decreased hydration in the skin because they dropped down to 91% from baseline. So I think that's interesting because this study does kind of solidify that we really need to apply moisturizers after cleansing, but even applying a moisturizer alone is very helpful. So statement 4 focuses on a different aspect of atopic dermatitis, and I'll read it to you. So to improve skin of color atopic dermatitis patient outcomes, we need to aggressively target inflammation to prevent long-term sequela. And our sequela in our skin of color patients is dyspigmentation, so hyperpigmentation or hypopigmentation. And you can see in this slide, this patient has hyperpigmentation, and sometimes my patients will have hypopigmentation, especially the ones with P. alba. We need to effectively manage pruritus, which is definitely more common in our patients of African descent. We need to counsel on the appropriate use of topical corticosteroids to minimize the risk of hypopigmentation, which we sometimes see in our darker patients. And very importantly, we need to consider cultural skincare practices. So when you look at the approach to skin of color in regards to atopic dermatitis, we do know that the guidelines for atopic dermatitis are applicable across the board. So it really applies for everyone, including our skin of color patients. However, few studies have specifically looked at specific racial ethnic groups. And even in our clinical trials, there are some disparities because sometimes the skin of color population is not adequately represented in clinical trials for drugs that are approved for atopic dermatitis. So there's definitely room for growth for our understanding of atopic dermatitis and skin of color. So we touched a little bit on the guidelines from across the world. I mean, this was a really nice comprehensive review. And what I want to show you is that every guideline recommends some type of moisturizer across the board. Every single guideline recommends that. Now, when it comes to cleansers, some guidelines do not specifically mention cleansing habits. The ones that do emphasize, like for example, Argentina, that the cleansers should have a neutral to low pH, as I just mentioned. So the ones who do mention cleansers do recommend a neutral to low pH and irritant-free, fragrance-free, low irritation type products. So let's move on to statement 5. And statement 5 is that clinical studies have shown that a skincare regimen incorporating a ceramide-containing moisturizer can improve atopic dermatitis and can increase lipid content, including ceramides in the skin, and they may offer clinical benefits in patients with skin of color. So the answer to that poll question was yes, but I want to present the data because there's some great studies on that. So before we jump into the studies, I do want to talk about our lipid lamella, which is the physiologic lipids in our skin that our skin naturally has. So we have ceramides, we have cholesterol, and we have free fatty acids. And these lipids work to moisturize, lower our stratum corneum pH. They actually have some antimicrobial effects. And I think most importantly is that they enhance our barrier. They keep our barrier intact. So across in many skin conditions, ceramide levels have been proven to be lower. So you can see here on the right here, it's acne is one of them, but today we're going to focus on atopic dermatitis. And in this study, there were healthy patients in the light blue, patients with atopic dermatitis in the dark blue, and you can see that the ceramide levels are lower for the patients with atopic dermatitis. The other thing that I think is very interesting is that multiple studies, at least 3 studies, have shown that ceramide levels are lowest in Black skin. So in that population of our skin of color population, consistently across multiple studies, there's lower ceramides. The other thing that's consistent across multiple studies is this increased skin reactivity in Asian skin. So this slide kind of summarizes some of the data that has been presented. I will tell you that all of these data is looking at racial skin properties. All of the studies are very varied. They're very varied, I guess is the best way to put it. So there's varying methodologies. So some might measure hydration or transepidermal water loss on the face. Another one might measure it on the legs. They might not clearly define the racial ethnic group. So did the patient identify as of African descent or of Asian descent, or did the investigator, identify that patient that way? They also, very importantly, had lack of standardized skin regimens prior to taking these measurements. So it's a big difference to check transepidermal water loss after washing the skin versus someone who's been using a moisturizer on their skin every day for the last week or so. So even though these findings are interesting, we do need to understand that we definitely need larger, more standardized studies to make very conclusive statements on this. The 2 things I do think are very conclusive, though, because there are multiple large studies, one was over 300 subjects, showed that Black skin had lower ceramide levels, Asian skin appears to be more reactive. So what are the clinical implications of this stratum corneum barrier differences that we see in skin of color? So we know that there's increased prevalence of atopic dermatitis in Black and Asian patients. Dr. Gonzalez presented that data that Black and Asian patients and Pacific Islanders are more likely to utilize healthcare for atopic dermatitis in the United States. There is, dryness is a big issue because on dry skin and darkly pigmented skin is very obvious, and patients don't like that who have darkly pigmented skin. Pruritus is a big thing that we do again show across multiple studies that itching is more common in patients of African descent. And then there's cultural perceptions. So ashy skin is that grayish discoloration to the skin when it's very dry, which is very something that patients really don't like and are trying to avoid at all costs. And of course, we know that East Asian populations often complain of very sensitive skin. So we need to take all of these into account when we're treating our atopic dermatitis patients. So the ideal moisturizer would be safe, effective, cost-effective. It would be free of additives, fragrance, any sensitizing agents. It would be pleasant to use. It should optimize that lipid and water content in the stratum corneum, because you keep hearing us talk about the barrier. And then most importantly, it has to have patient satisfaction, because no matter, they won't use it unless they like it. So very important also. So I'm going to talk a little bit about this multifascicular emulsion system, which is a unique way to deliver moisture to the skin. So the MVE is a multi-phase oil and water emulsion system that has concentric spheres of oil and water in phases. So what this MVE system does is that it traps the ingredients into its oil or water layers and then releases it slowly layer by layer into the skin. Why is this patented and why is this unique? It's because instead of a quick burst, which we see with traditional moisturizers, you get the moisture into the skin slowly over time. It's a sustained release. So the hydration that's seen is observed over a longer period of time. So in the main technology here is that MVE technology that I just discussed, and the inclusion of ceramides, which are really important for our skin's barrier. So this is the question, and this is the data I'm going to present to you. I'm really excited to present. Can topically applied ceramides be incorporated into the stratum corneum, or do they just reside on top of the skin surface? When you put a moisturizer on, does it just stay right there, or does it actually change our skin? So let's look at the data. So this study was actually done in 2 phases. This was called the Restore study. And phase 1 was just looking at the lower legs of 22 adults ages 20 to 66 with dry skin and a history of eczema. And then you can see this is showing this little area here is the 2 legs. And site 1 and 2 were the CeraVe cream and lotion. Site 3, 4, and 5 were the reference creams, so some alternative moisturizers. And site 6 was untreated. And in this study, the CeraVe moisturizer significantly increased hydration for more than 24 hours after a single application. Remember, I just talked about that multivesicular emulsion technology that allows that moisturization to be delivered over time. And by comparison, the other emollients did not have any significant increase in hydration. So you can see here, and this is from phase 1 of that Restore study, this big peak in hydration as measured by capacitance for the CeraVe cream and lotion. The lotion's in blue, the cream is in black. And then that was sustained over the 24 hours. And then you can see here that the other moisturizers really didn't have any significant difference over the non-treated skin as far as moisturization. So that showed that applying a moisturizer with ceramides and MBE technology increases hydration in the skin that lasts up to 24 hours or more. But what about, does it change our actual skin? Do the physiological ceramides in our skin change? And that's what phase 2 of this study looked at. So this is a very busy slide, but basically this was published, it was a poster and also published, that looked at the change in ceramides. So how do you measure ceramides in the skin? You measure it with something called tape stripping. So you literally apply a piece of tape to the skin and take it off, put that tape into solvents, and after the solvents dissolve, you can look at the amount of ceramides. And with each application of the tape, you're getting deeper and deeper into the epidermis, so you're able to see the ceramide content in the epidermis. So in the Restore phase 2 study, they first looked at transepidermal water loss. So they applied the CeraVe, which is in orange here, and compared it to a reference cream. And you can see transepidermal water loss is lower with the CeraVe cream here and also here. So the lower transepidermal water loss, and that is to be expected. But the real interesting thing, which was our poll questions, what happened to our ceramides? And this is looking at the ceramides. So remember, I just talked about the tape strip number. As you go across on this axis, the greater the number of tape strips, the deeper into the skin you're getting. And you can see here the CeraVe is in blue. You see that these are the lipids. So the lipids are higher in the CeraVe treated skin compared to the reference cream treated skin. So it's showing that applying this moisturizer with ceramides actually did increase the ceramides within the skin compared to a reference moisturizer. In this study, the patients used the creams, the CeraVe or the reference cream twice daily for 4 weeks. They were 34 subjects, and they were intra-subject control, so it was within the same patient. This is looking at stratum corneum hydration, and you can see here the CeraVe is in the orange. There's increased hydration, and of course a decrease in visual skin dryness, and this was in all age groups measured. And then they looked at skin sensitivity. And for this one, they put an irritant on the skin. In this case, it's the SLS patch. So at the end of the study, they've been using it twice a day for 4 weeks. Then they put on this SLS patch on day 29, removed it on day 30, and then looked for signs of irritation on day 31. So there's 2 ways to look for irritation. You can look for redness, and you can see the CeraVe treated skin had less redness after applying that irritant. And you can look for a change in transepidermal water loss. And again, the CeraVe treated skin was less likely to have water loss after applying an irritant. So what you can conclude from this study is that CeraVe improved the barrier, it reinforced the barrier, increased hydration, decreased dryness, protected the skin from irritants, and in this study, it was more cosmetically acceptable than the reference cream. Now, this is another study looking at topical ceramides, a topical ceramide-based cleanser and moisturizer as monotherapy for atopic dermatitis. 151 subjects. One group was older, so adolescent, teenagers, basically, and adults, and one group was children 11 and under. And what they found is that from day 0, which is in the light pink, to day 42, which is in the dark pink, there was a reduction in dryness, very dry skin, crustiness, very crusty skin, itchy skin, very itchy skin. That's a huge reduction in itching at the end of 42 days. And most importantly to me is a reduction in atopic dermatitis symptoms. And this was in group 1, which was the 12 years and older group. And then when you look at group 2, which was the younger participants, you saw the same thing. You can see that at baseline, most were very dry, and you can see they are now more dry. So that's why this is a little bit higher, but it's because they went from very dry to dry. But you see reduction in crustiness, that was statistically significant, that change in itchiness. And again, to me, what's most important, from baseline to day 42, a reduction in atopic dermatitis symptoms. Now, this is another study that looked at the legs of 49 women with dry to very dry skin and did that same tape stripping technique to see if there was an increase in ceramides in the skin. So they used the product every day for 4 weeks, and then they came in for measurements. And you can see here that there was an 11% increase in total ceramide content at the end of 4 weeks. And this was even partially maintained 2 days after completely stopping the ceramide cream. There was a 14% increase in cholesterol, and there was an 11% increase in free fatty acids. So this study suggests that applying a moisturizer topically can actually, with ceramides, can actually affect the stratum, corneum, physiologic lipids in our skin. So in conclusion, there are racial and ethnic differences in the clinical presentation of skin of color. We do know that treatment of atopic dermatitis in skin of color should be proactive, target inflammation, protect the barrier, and consider cultural practices. Physicians can recommend prescription treatments and moisturizers, but we also have to be sensitive to cultural views and practices to help understand that in the context of our skin of color patients, they might be using a lot of fragrance or over scrubbing, and we need to educate and address those issues. Addressing skincare cleansers and moisturizers in all patients is really important. All of the international guidelines talk about that. We really do need to address habits that may be common in skin of color, like over cleansing and scrubbing. Clinical data does demonstrate that a skincare regimen incorporating a ceramide-containing moisturizer does increase the lipid contents in the skin, including ceramide. And as we know, because some of our skin of color patients have lower levels of ceramides, skin of color patients may specifically benefit from the topical application of ceramide-containing skincare products. So that concludes my presentation. Thank you so much. And now we're open for questions.
Thank you so much to Dr. Gonzalez and Dr. Woolery-Lloyd. So now if anyone has any questions, we would like to invite you to enter your questions in the question chat pane. And then if you have any additional questions after the presentation, you're also welcome to email them to us at info@rbcconsultants.com. And we would like to again thank our sponsor, CeraVe, for making this educational event possible. And so at this time, we are going to open the floor for some questions. So I've got a question here from the audience. So we'll start out with this. So when people want a natural moisturizer, what do you think about olive oil?
That's a great question. I'll tell my thoughts, and Dr. Gonzalez, you can also give your thoughts. So there were some studies that showed that olive oil actually increases transepidermal water loss and is not helpful in atopic dermatitis. So I know a lot of our patients, I practice in a place where people always want to use natural, quote unquote, natural products and natural oils. And we really do need to communicate to our patients that not all natural oils are helpful, specifically in atopic dermatitis. Olive oil specifically has been studied, and it was shown that it didn't make it better and may have made it worse.
Yeah, I agree with you, Dr. Woolery-Lloyd. I quote that study to parents, and I tell them specifically about olive oil and that other oils may be okay. And then when parents ask also about the word natural and they prefer natural, I always caution them that natural may not always be better, because things that are natural usually are things, they may have a longer list of ingredients, of inactive ingredients that may include fragrances and other things that might be irritating to the skin. So just because it says natural doesn't mean it's always better. And specifically oil, I discourage the use of that.
The other thing I always tell my parents is that grass is natural, and we wouldn't use a grass soap, you know, on our atopic patients. So you know, it's tough because we do need to address that, and I completely understand why patients are interested in learning more about that. but we really have to emphasize the data.
All right. Looks like we have another question. Is fragrance-free the same as unscented?
So no, that's another common question. It's not a common question, but patients always might be confused about fragrance-free and unscented. So fragrance-free means there's no added fragrance. When you're formulating skincare, it means you're not adding fragrance. Unscented means you can't smell it. So there is actually a fragrance called unscented. So formulators can add an ingredient to neutralize a scent, and then that product is called unscented. So our atopic patients really need to look for things that are fragrance-free, because that means there's no added fragrance. Ironically, you might smell something because some natural ingredients actually have an odor to them, but there's no added fragrance, whereas unscented means that you can't smell it. It has a neutral scent.
All right. So I have another question came in that says, why do you think itch is so much more common in Black patients?
So that is the data looking at mast cells showed that mast cell granules were larger in patients with Black skin. And so there's maybe it could have to do with that histamine release. Clearly itch across the board, not even just in eczema, but in other diseases. Itch is a huge component. Prurigo nodularis is more common in Black patients. And so there is a theory that it could be due to those larger mast cell granules. And then, of course, this question about the barrier that we talked about through this whole talk about, the decrease in ceramides, possibly increase in transepidermal water loss. So those could also contribute.
I think that, that known difference is another reason why much more research is needed into kind of the pathogenetic differences in the different skin types, skin of color patients versus other skin types, to see what exactly, what are the key pathogenic factors that are leading to what we're seeing clinically, which is there is more severe itch and it is more persistent.
Right.
So,
We definitely, I totally agree with you. We definitely need more research, because we need answers to those questions. That's a great question.
Great. Okay, so we have one that has come in asking about a recommended skincare routine.
Dr. Gonzalez sees a lot of kids, so maybe you could comment on what you say for kids, and I can tell what I say for adults.
Right. Yep. So, when I educate parents, I do a little bit of education at every visit. It's so important, right, to make parents understand that this is not something that we're going to give them a treatment and it's going to go away, right? The chronic nature is super important to lay down right away, that, even though you're perfect with everything you do and the treatments, you follow my instructions, it's going to come back. The key is to try to prolong the time between the flare-ups, the time between the itching period. So the daily care of the skin is so important because of, all that we spoke about in the presentation about how there's genetic, inherited skin barrier dysfunction. That's just your skin you're born with, right? So it's like having curly versus straight hair. You're born with this more dry, more sensitive skin. It requires a daily care with a moisturizer every single day. And I do choose, moisturizers with this technology that you kind of discussed, the data behind. We use moisturizers like that to help repair and restore what we know is missing in the skin of patients with atopic dermatitis. So we choose the moisturizer specifically to repair, and I try to educate them on that so that they know that the moisturizer is actually doing something. The moisturizer is actually being used to help prevent the flare, to extend the period between the next flare up. So that's super important, making that moisturizer every day, whether they're flaring or not. And then I always give them a spot treatment for flares, depending on the severity, the location on the body, and what they've tried in the past. So, I'll choose from the different prescription medications for those spot treatments. Parents use those spot treatments twice a day, and then seal it in with that moisturizer head to toe. I do recommend daily bathing. Parents sometimes are surprised by that, because I know there's a lot of varying recommendations out there about frequency of bathing and not bathing every day. But after a certain age, especially once kids are crawling and sticking everything in their mouth, I really think the benefits of daily bathing outweigh the risks of the harm of, prolonged contact with water. So as long as it's limited to less than 10 minutes, 5 to 10 minute range, And then the moisturizer is used, or the treatment and the moisturizer is used right after coming out. I usually recommend within 3 minutes of coming out of the bath to apply your treatment and then the moisturizer. I do like the daily short bath with a warm temperature water.
I do basically the same thing in adults. In my adult atopic dermatitis patients, I really emphasize moisturization. They tend to be pretty good because culturally, my patients, or a lot of skin of color patients, moisturize a lot because that is a part of the daily culture. So the key is just choosing the right moisturizer that's restorative. And so my recommendations are very similar, bathing daily, immediately applying the moisturizer afterwards, reapply moisturizer, keeping the skin hydrated, and spot treating the areas where you have the severe flares with topical steroids or immunomodulators.
Great. Well, that is all the time that we have. So we thank you both for participating this evening, and we thank you to all of our attendees for joining us. And we look forward to another Skin Chat webinar in the future. Thank you. Good night.
Thank you.
Thank you.